Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
Hello, my name is James MacNamara from the University of Virginia, and welcome to the In the Thick of It podcast. It's my pleasure to introduce our guest, Dr. Milind Desai. He is the vice chair of the Heart, Vascular, and Thoracic Institute at Cleveland Clinic and the director of the Hypertrophic Cardiomyopathy Clinic. We're here today to talk about the ODYSSEY trial. Welcome, Milind. How are you doing?
I'm good. Thank you, James, for having me here.
Excellent. I think the ODYSSEY trial was a big topic of conversation over really the last year since the top line results were announced. I was wondering if we could start by just kind of bringing our audience up to speed about the purpose of the trial, who was enrolled, and what did you find?
Yeah. So thanks again for having me here. And yes, it would be good to revisit. So, as we've seen a revolution of new precision therapies in hypertrophic cardiomyopathy, specifically obstructive HCM, in the context of emergence of cardiac myosin inhibitors. Lots of phase 3 randomized controlled data, which has shown that these patients benefit tremendously. So, as all of us know, at least a third of the patients with HCM aren't truly non-obstructive, and they also have symptoms likely driven by diastolic dysfunction, small cavity, microvascular ischemia, arrhythmias, coronary disease. And we don't really have, if we thought we had paucity of data for obstructive patients, this is really, there is real paucity of data. So there is a desire to develop therapies that work in the non-obstructive HCM population. And with the understanding that CMIs could play a role in overall HCM, the natural next thought was, why should we not try and test this in a non-obstructive population? So that was the basic genesis of the ODYSSEY trial, which, as you know, was a phase 3 trial testing mavacamten versus placebo in symptomatic NYHA class 2 and 3 non-obstructive HCM patients.
Yeah. And, I was 48 weeks with mavacamten. And what did you find with the kind of the top line results?
Yeah. So these patients, and as I alluded to, these were truly non-obstructive, where we did baseline stress echocardiography to rule out latent obstruction.
Yeah.
They were obviously very symptomatic, high biomarker burden, high LV mass, all that stuff. And they were followed for 48 weeks with a dose titration scheme that was driven by ejection fraction. So the threshold that were used was, if your ejection fraction is less than 50%, you would require interruption, similar to what we have the commercial mavacamten story in obstructive HCM. So bottom line is, what we found, these patients, basically, the mean age was about 55 or thereabouts. The average duration of disease was about 10 years. About 30% of these patients had obstructive HCM. 30% had atrial fibrillation, history of atrial fibrillation. And their Kansas City score was around 57, so very significantly symptomatic. And their peak VO2 was in the 17 to 18 mils per kilo per minute range. And the two groups, placebo and mavacamten, were very well matched. So the population, one can discuss, did we select the right population or what? But this was, this is the population that plonks in your clinic, and you have no idea what's going on and how to take care of these patients. So what did we find? The primary endpoints were dual endpoints. One was Kansas City change from baseline in KCCQ 23, the composite summary score, the CSS, and change from baseline in peak VO2. So these were the two primary endpoints. Additionally, we also studied a slew of secondary endpoints, including VEV CO2 slope, NYHA class, biomarkers, and of course, safety, ejection fraction reduction, etc. So the punchline, the two primary endpoints did not meet statistical significance. The p-values were 0.05 and 0.06. So they missed the p-value by a whisker. But be it as it may, it did not result in statistically significant improvement from baseline in peak VO2 or Kansas City cardiomyopathy score. Because this was pre-specified as a hierarchical endpoint, we did not do additional p-value generations. The other thing, important thing, what we found obviously was we wanted to look at what happened to subgroups. And vast majority of the subgroups, there were no significant differences in terms of behavior. There are a couple of things that we noticed that we will talk about later in this discussion. The additional thing, what we found was that compared to placebo, a significantly higher proportion of patients on mavacamten required treatment discontinuation. 42 patients, or 14.6 in the MAVA group versus 5.2 in the placebo group. And EF less than 50% occurred in 62 patients versus 5 patients in placebo. But important to note that this was transient reduction in ejection fraction, and pretty much everybody got their ejection fraction back to baseline and normal after treatment interruption. One patient withdrew consent, and 2 patients had EFs in the 40s with no additional follow-up. Similarly, there was about 19 patients had congestive heart failure in the mavacamten group. However, only 5, it was in the setting of ejection fraction less than 50%. So this goes to show that this is a complicated patient population with a variety of reasons why they develop symptoms.
Yeah, and that's of course a challenge that we see with the obstructive patients too, is a lot of this,
Exactly.
the heart failure is also a part of the disease.
Yeah, absolutely. And the other few things we noticed was obviously the dosing we talked about was primarily driven by ejection fraction thresholds. Unlike the mavacamten dosing in the obstructive HCM population, about 50% patients were on the higher 10 or 15 milligram dose. So that may have driven, obviously we were targeting EF as an endpoint. So that probably is explained by that. And obviously, as I alluded to, these patients had more advanced disease and a longer diagnostic or longer time from the original diagnosis. Another important and surprising part we saw was there was a 10-point improvement in the KCCQ score in the placebo arm, which, we've seen that in other heart failure trials also, because a lot of times what ends up happening is these patients come and they get better treatment for everything, their ischemia, their diuresis management, their AFib, etc. So while surprising, it is not really entirely surprising. But on the flip side, it does point that we may have, look, these were the endpoints chosen for the trial, and you live by the endpoints. But it definitely raises a question: should we be exploring alternate endpoints for a trial with this kind of patient population? And of course, we don't have long-term data. This was 48 weeks. So I think in summary, a neutral trial in terms of primary endpoints. We will talk about some of the additional signals that we are seeing. The dosing was driven by ejection fraction, and there were a sizable proportion who needed a temporary interruption, which may have influenced the end result. And of course, the all important placebo effect.
Yeah, and I wanted to kind of look into that placebo effect, just because I mean it's worth saying that the intervention arm had an improvement of KCCQ of 13, which is an enormous effect. It just nullified out a little bit to 3 with the placebo. One of the questions I wanted to ask you is, do you think being one of the first, I mean, this is the largest clinical
Yeah.
trial. This may be the largest clinical
Yeah,
trial
this is
ever
the
done.
largest.
Yeah.
Yeah, I forgot to mention this was 580 patients. So this is the largest HCM trial ever conducted.
And in a population where the only randomized control treatment has been exercise training.
Yeah.
So I think that, speaking to a sicker population where
Yeah.
that training may not be as effective or as practical is enormously important. Do you think that some of that placebo effect could have been from just kind of a desire for the first drug to be shown to be effective?
Yeah, I think the placebo effect in symptom, physician reported outcome, not patient reported outcome. The placebo effect is a lot of it is desire to, yes, I want to feel better. I want to feel better. It's the flip side story is the statin intolerance story. They Google statin intolerance and all of a sudden everybody and their grandmother has muscle aches. So here it's the exact opposite. So I think it is multifactorial, as I alluded to, better treatment and a desire to get better. So people, feel that they are going to err on the side of, hey, I am feeling better because I'm part of a trial. So all of the and besides, as all of us know, KCCQ was not developed in HCM specific population. So we are trying also to fit a square peg in a round hole. But but I don't want to sound defensive. This was the endpoint chosen, and this is the endpoint we live with.
Yeah, well, I think, and that's a good segue, I think, to some of the endpoints that did work quite well, in the biomarkers. And you guys, the team released a sub analysis, two sub analyses in Jack, a couple of months ago, and I'd like to talk about the effect of mavacamten on both BNP and troponin in these patients with non-obstructive HCM and how that relates to the clinical outcomes of the trial.
Yeah. So as you rightly pointed out, two additional sub studies were presented at ESC 2025 and simultaneously published in JACC. And one of them was the biomarker study, which showed both biomarkers in the mavacamten group improved by 53%. So that's a tremendous improvement in terms of the biomarkers. So at a pathobiologic level, something is happening to the sarcomere where the markers, the hormonal markers of stress are significantly improved. Is that pathobiologic improvement big enough to translate into the macro improvement of a peak VO2 or a KCCQ? I think that, so it's not to say, it's one thing to say that across the board, nothing works. It's what's the proverbial saying? Don't throw the baby with the bathwater situation. So
Yep.
there's deeper understanding of pathobiology that we are learning. So that's the biomarker story. The other story is we also did echo analysis, and there were multiple markers of multiple directional improvement in terms of favorable cardiac remodeling in mass and diastolic function, etc. So there is something happening at a pathobiologic level which did not elevate to the level of the primary endpoint positivity. Now, one can make an argument all the changes that we talked about in biomarkers and echo are also seen in obstructive HCM patients. So maybe, it's kind of like one of our older former presidents said, is the economy stupid, right? Maybe after all here, it's the LVOT gradient that is primarily a big driver of symptoms where these CMIs seem to work. But be it as it may, there is something happening at a pathobiologic sarcomeric state in the mavacamten group that was not observed in placebo group.
Yeah, absolutely. And for the audience listening, we're gonna link all of these articles in with the episode. I mean, the biomarker results are striking, and it's that graph that we're kind of used to seeing in the obstructive, where the placebo group is a straight line and the intervention group drops down and sustains. I know in that Jack analysis, you did look at kind of the people with the or the response to biomarkers in terms of the primary endpoint. And of course, we'll pause and say that, as you said, when we look at FDA approval and the use of the drug, there are rules, and we would use the primary endpoint. There's a really nice editorial with these articles talking about that there's still a lot to learn from this data. So I don't mean to ask you, did it work in certain patients, but what is the relationship between the change of biomarkers and the particularly the symptom outcomes or the functional outcomes in patients with non-obstructive HCM?
Yeah. So there, the folks with the highest biomarker improvement also had a good improvement in their remodeling markers on echocardiography. So it's not that one is going this way and the other one is going this way, right? It is both of them are rowing in the same direction. Both the boats are. So that's why I keep alluding to there's something favorable happening at a pathobiology state. Now, I am going to also talk about we presented another sub-analysis at AHA and the HCM Society scientific session, where we looked at in a study with a p-value of 0.05 and 0.06, there are some patients that benefited. So we wanted to understand what the story was. So we further did a deeper dive and looked at two populations. What happens to people who have an ejection fraction of more than 65% versus less? What are the characteristics of patients who had no atrial tachyarrhythmias at baseline versus who had atrial tachyarrhythmias? And a third analysis, what happens to two groups where one group is EF more than 65% and no tachyarrhythmia. So the combination of the first two groups versus the other. And sure enough, what we found was the patients in the better group or less sicker group, they had shorter disease, they had clearly no AFib, EF was better. Their baseline characteristics were better compared to the more advanced disease group. And sure enough, all the primary and secondary endpoint, again, this is a secondary analysis, so we are not going to talk p-values, but there were directional improvements that would be considered in the significant realm in the group that had EF more than 65% with no history of tachyarrhythmia. So there is a subgroup of non-obstructive HCM patients where this works. This paper is, again, as I alluded to, was presented at AHA and is coming out in JACC in early part of 2026. So we are learning. Yeah, I don't think the story is quite finished yet.
Yeah. And, it sounds like, AFib is a big topic in CMIs right now with the obstructive patients, and may be related and contribute to, some of that EF drop, at least in the obstructive. So it makes sense to look at the AFib-free cohort. And it sounds like what you're describing, these are drugs that ultimately target the LVOT gradient through reducing that hyperdynamic state. I think that's clear in the obstructive patients. So is there a kind of a phenotype of non-obstructives that are also hyperdynamic? They just haven't manifested that obstruction for whatever reason. Do you think that's likely?
I think so. Look, to me, the story of CMIs, I think a lot of it is tied to hyperdynamicity, right? It reduces the hypercontractile state to a normal contractile state. And that's the sweet spot where you see the favorable effects in obstructive and in, for whatever it's worth, in a subgroup of non-obstructive patients. So I think and once it works on that pressure phenomenon, perhaps maybe that's the bigger driver of all the other remodeling things that are happening, favorable remodeling things that are happening. again, these are all hypothesis generating scenarios, and we need to study more.
Well, and in a drug where we have no proven pharmacotherapy, anything we can learn is valuable. So the last
Absolutely.
question I wanted to ask you is what do you think is next in the non-obstructive space? We have Odyssey, we're seeing these kind of sub-analyses. What do you think the next big development in non-obstructive HCM is likely to be?
And we are waiting for the results of the Acacia trial. So let's see what that reads out. There's other drugs in development, the EDG 7500. There's the Sonata HCM trial. There's that cardiac mitotrope. I cannot ever pronounce I call it the Nina drug.
Internal plug. We have episodes with Charlene Day to talk about Sonata and Marty Marin to talk about Fortitude from the prior.
And the other thing which I am intricately involved in is gene therapy. So, that is probably the next frontier. We are working through the initial learning phase, but that is promising to me. So I think, and look, all these therapies aside, what's the most important part of it is that the diagnosis and the disease is front and center. We are working hard to enhance diagnosis, refine diagnosis, weed out the differential diagnoses, the phenocopies, etc. So, the rising tide floats a lot of boats here.
Yeah, and I think to tack on to that, the relentless pursuit for obstruction. 'Cause I think one of the strengths of Odyssey was the stress echo that was performed along with it. And, if we're not stressing our patients to look for that obstruction, we're going to be missing opportunities in a cohort where it is well proven that these drugs help.
And I'd be remiss to say, even look, with the explosion of these medical therapies, even the surgical or the invasive procedures are getting better and better refined. We have, even in the interventional space, we have multiple procedures. There are novel ways people are doing surgical myectomies on a beating heart, etc. So, the space is ripe for a lot more stuff. I think we are just scratching the tip of the barrel.
Yeah. Well, thank you so much for joining me. We've been discussing the Odyssey trial, both the primary results as well as the follow-up biomarker echo data and an upcoming sub-analysis with showing responders. And all of those papers will be linked in the description. And Dr. Desai, thank you so much for joining us on this episode of In the Thick of It.
Thank you very much for having me. This was fun, James.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.